like to welcome you all for our annual Nodo Memorial Lecture. As tradition, just a little bit of background about Dr. Nodo for people who don't know him. Dr. Nodo joined South Nassau in 1952. He was one of the first pediatric surgeons here at the hospital. And he was very well known for two things. One is meticulous surgery and meticulous dressing. He used to have in those days also he had his own tailors for which he used to go to the city. And one of his sayings was, which he borrowed from Halstead, is that treat tissues gently and they will respond to you kind by healing. So one of the previous years, Dr. Nicholas Licalzi established this Nodo Memorial Lecture, and the purpose was to bring an established clinician who can add to the knowledge and service here at South Nassau. So today I have the distinct pleasure of introducing Dr. Michael Marin. Now, as everybody knows that we will be soon joining the Mount Sinai Health System, and to me this was the best opportunity to bring somebody of the stature of Dr. Marin to South Nassau. And we have some dignitaries in the audience who like to acknowledge Dr. Arthur Klein, the president of the Mount Sinai Health Network, and he's been instrumental in helping us to go through this relationship. So Dr. Marin, he has such an extensive CV that I picked out a few things which I found very, very provocative and interesting. He obviously joined, he trained at Mount Sinai Medical Center. He did his surgical residence in Columbia and vascular fellowship at Montefiore. And in 2003, he was appointed the chair of Department of Surgery at Mount Sinai. And then in 2007, he was given the title of Jacobson Professor of Surgery. And then 2014, he became Surgeon-in-Chief of the Mount Sinai Health Network. He has an international reputation in vascular surgery, so much so that in '92, he did one of the first minimally invasive surgery for aortic aneurysms using endovascular grafts under local anesthesia. He also performed multiple procedures, again, innovative in the field of vascular surgery. In fact, he was one of the first ones who did, in 1994, a ruptured AAA. That was the first case he was done in the world, so that's his level of innovation. In fact, he holds many patents, over 12. He formed a company in 1997, which was called TerraMed, and which was finally bought over by Johnson & Johnson in 2001. So as you can see, he works in surgery because he loves to. He's been obviously a very active educator, innovator, clinician, teacher. He's got numerous awards from any society you can think of. And he's written over 200 articles, multiple book chapters. And over the years, he has taken the Mount Sinai Surgical Department to the age of, beyond the age of modern age of surgery. I mean, if you sum it up, he's a clinician, researcher, educator, innovator, and he's well deserves the praise and honor and reward. And we are extremely proud and very pleased that he has agreed to give this lecture to us. So please help me welcome Dr. Marin.
Thanks for that introduction. It's a pleasure to be here and to give this special lecture for several important reasons. When we look at a department, we look at an institution, it is built on the people, the physicians, the nurses, the staff, people who make the wheels and engine of our hospitals and our medical centers run. That's really the foundation of every great medical institution. And the foundation of a great department is one that has great people, and that the individuals who run those departments remember those who supported, built, and created the foundation. Having been chair of a department very similar to the one you see here for the past 15 years, I can tell you with a good heart that it is the people who came before me that really set the foundation, set the culture, set the temperament of what our department and our institution is. And it is so important to have memorial lectures, remembrances of people who came before, because it gives you a sense of who you are and where you came from. As I sat down and thought about what would be appropriate to give for this very special Dr. Noto Memorial Lecture, I struggled with it a little bit. I've spent a fair amount of time, as you've heard, working in the field of minimally invasive aortic aneurysm surgery. In fact, I could say with good confidence that I spent my entire professional career with a focus in this area. I had the good fortune of beginning my career. I was 2 months out of fellowship and in practice when I saw this patient in my office who had a large abdominal aneurysm, was inoperable on a standard way, and we had no other alternatives at the time. And to my fortune, I discovered that there was a man in Argentina who was doing this kind of idea and had done it 3 times successfully, creating a device that would allow him to minimally invasively treat a patient as sick as this. And then in November, I did the first case together with him here in New York. He came up from Argentina. As I put this lecture together, I was thinking, gee whiz, I haven't changed much. Under that hat, I have a full head of hair, and the color's a little bit, I was dyeing it back then, so it really hasn't changed much. But a lot has happened over the past 25 years, and I would say I've spent this period of time, and I calculated, I've given this talk about minimally invasive aortic aneurysm surgery over 2,690 times, all over the world. And I enjoy talking about it because I have a passion for it, and I have a passion for the success and the things it has done for our patients over the course. And having been able to participate in its development, both on a clinical and a research basis, it's given me a tremendous sense of pride. But I thought I'd change a little bit and ask for your indulgence to allow me to experiment with you and talk about something else. I also have an interest and a passion for this field known as global surgery, or it's a piece of the global health area, and as I tell you a little bit more about it, you'll see about the significance of it and what its impact is and what our responsibilities as healthcare providers might be in this world as it relates to offering surgical care elsewhere. This is a personal tale, but as I get further into this, you'll see that there's plenty of opportunities, and as we begin to build our relationship as 2 separate individual organizations into one, we are looking for a bunch of good people who are continually and persistently interested in the field of global health and would like you to come and think about joining us in this venture to change the course of surgery on a worldwide basis. Let's look at some basic situations and basic data. There are 5 billion, that's with a B, 5 billion people worldwide who do not have access to safe surgery that they can afford or even obtain. 5 billion. If you look at that on a basis of the size of our world, we're looking at 7.5 billion people, thereabouts, plus minus. That means 5 of the 7.5 cannot get an appendectomy if they need it, or repair of a hernia, or strangulated hernia, or treatment for breast cancer, or any other surgical therapy. They're denied because these locations, these places don't have access to a facility, or if there are some facilities in the area, they're priced and there's a financial situation set in motion that they can't achieve care because they can't afford it. How about that? 5 billion people. And statistics that are available from 2010 show us almost 17 million people die annually from diseases that are surgically correctable. This is over 30% of the worldwide deaths. And to put it in even a better perspective, another important statistic, because we invest very heavily in global health in infectious diseases. The Gates Foundations and other have done a tremendous amount of positive things with vaccines and other treatments for infectious diseases. But if you take all the deaths that have occurred from tuberculosis, AIDS, and malaria, the three most common and important infectious regions and infectious problems, that constitutes 3.9 million people. So 16.9 from surgery, 13.9 from all of the other infectious problems that we associate with problematic health care on a worldwide basis. This is a huge, huge problem, and one that needs to be attacked and looked at more focally. Now, because I am a surgeon, I tend to break things down into very simplistic things. And what you'll see right now to follow up will be some very simple ways to look at the problem, but I think they're very accurate. I think they really tell the story correctly. If you look at the distribution of disease, you'll see on this heat map that the majority or a big percentage of the areas that have virtually no access to surgical care sit in countries that Dr. Klein's personal president would describe as an S-hole country. But in essence, they are important regions of the world, and many great jewels and diamonds come out of this on an international, on an intellectual basis, and they're areas that need to be looked at more closely. But clearly, Africa and parts of the continent adjacent are all important regions that have problems associated with access to surgical care. What is the most common explanations you come up with? And this gets to the point I was making a moment ago about simplicity and my way of looking at things. Well, the first most common reason that people do not invest in surgical enterprises on a worldwide basis is they believe it's too expensive. I take this is one of your urology rooms and your beautiful entranceway, and people look at what we do here in this world, in this part of the world, and they look at surgical enterprise and they say, gee whiz, the equipment, the people, the training, everything else is so expensive, we can't possibly initiate such a project in our underserved parts of the world. The second issue is associated with complications. People think it's just too complicated. They look at surgery, particularly people who don't do surgery, and think, gee whiz, it just takes years and years of training. The average surgeon goes through 4 years of undergraduate school, then 4 years of medical school, and then between 5 and 6 years of residency training in surgery, and often another 2 years of fellowship. It just seems so complicated in educating a surgeon that people come up with the concept that we can't even begin to think about offering surgical care in our community, in our country, because the complicated nature of this enterprise leverages us out of being able to offer it. So too complicated and too expensive. These are really, you could actually use these two concepts to describe the predominant reasons why surgery doesn't happen in so many parts of the world, and why 5 billion people worldwide live without the opportunity to have even the simplest surgical interventions. So we began a number of projects, and this goes back a little, almost 20 years ago at Mount Sinai, and became more substantive the past 15 years to look at projects that we could be involved in that might, one, investigate it, understand a little bit better about why this is true, why we have such a poor amortization, if you would, of surgical knowledge on a worldwide basis, and how technology might impact on that, but also what we might do to impact on it. What can we do to change that? And like many institutions, we began with our global health program, sending people around and developing programs in multiple countries around the world. And this is somewhat arbitrary. A physician would come up and say, I have a connection in this country, I want to begin a project there, so off we would go and do that. Another person would be have a communication from someone in a country that had a number of problems, such as this plastic surgery group that had a bunch of children who sustained severe burns and needed plastic surgical reconstruction. So we put a team together and send there. We developed these ideas of providing education to try to train groups in these countries, and create dedicated missions around specific surgical problems. Get the right group of physicians, a right group of surgeons, the right teams together, and send them to sites where they're necessary. And frankly, most of these activities just didn't get us to where we wanted to be for a whole host of reasons, and we'll define those reasons in a moment. We also developed programs around first responder. You know, our department created a program where we had a group of surgeons, nurses, OR technicians, support staff, all the necessary ingredients to create a surgical enterprise in a box, if you would, ready. And we rehearsed this process and put our team together with equipment in boxes and suitcases, everything ready to go should there be a need. And sure enough, our first foray into this was in January of 2010, looking at almost 8 years ago when the huge earthquake occurred in Haiti, which is really a hop, skip, and a jump away from our location, became an ideal area for us to exercise what we had been doing and try to provide help in this region. And we put together a team. We were lucky enough to get one of our generous donors to give us a chartered plane. Through connections to additional board members at Mount Sinai, we had access to Hillary Clinton, who was very powerful as in the government in New York at the time, to get us access into Port-au-Prince. And off we went to begin to establish a surgical hospital in that area with 27 personnel. And obviously what we saw there was just quite catastrophic. The death toll was enormous. The number of injuries and the types of injuries was so broad-based. Many, if not most of them, had a surgical enterprise. And we went to work with the small residual infrastructure that was present there, with the equipment that we brought along to set up a surgical facility. And everything was from scratch. And we set up our instruments. We created our own sterilization process. There was no water. There was no electricity, obviously no sterilizers. So we using a series of irrigating solutions. That's how instruments were sterilized. And off we went to operate and do what we do best as surgeons, as nurse surgeons, as support personnel in the operating room, and create an opportunity to save lives and provide our presence. But again, we're back to the same concept. This was a very needed process, and with what we did there in Haiti, we were able to teach and establish and begin a durable first-generation operating room in a place that had nothing at the time when we arrived. And by the time we left, over 2 weeks later, we left behind an operating room facility with a reborn group of surgeons taking over the responsibility of their community. But still, only a drop in the bucket of what needs to happen on a worldwide basis if we want to have an impact on this 5 billion people. Now, the first part of changing things is often getting public awareness of the problem. And by 2015, for the first time, we were starting to see national and international discussions about this problem and its magnitude, the absence of surgery. And Dr. Marin from Boston and his group really pushed their way deep into the regulatory side of this. We've got a very important op-ed piece in the New York Times, which really outlined, very importantly, the problem, both the size of the problem and some of the challenges that are in front of us if we're going to do something about it. Back to our idea, what do we do about making it too complicated and too expensive? How do we change or alter this curve, bend this complication, this expense curve in a way that it can make a difference so we can begin to offer these things in a more effective way on a worldwide basis? Well, first and foremost, let's look at the surgeries we do and how they might map out to the reasons why we shy away from offering these therapies. Obviously, we deal with coronary bypass surgery, open heart surgery. This is complicated. It is expensive. And there's no way to make it less than that. It's gonna cost us something in terms of education and training. And complex gastrointestinal surgeries and bypasses and so forth are also complicated surgery. Doing what I do, these aortic aneurysm repairs, requires technology, training, equipment that is highly costly and complicated to implement. And doing the rare surgeries such as separation of conjoined twin, these are all complicated and expensive things. But if you look at it, these are all inpatient surgeries. And inpatient surgeries, this is data from 2010, it's changed even further in the direction of ambulatory side. More than 60% now of all surgery done in this country is done in ambulatory facilities, can be done safely, and the patient's discharged home. And if you take that premise, you can say, well, let's stay away from the complicated surgeries and focus on outpatient things in regions where surgery doesn't exist, where even the simplest type of operations are not available. Similarly, if you look at the economics of it, more than 80% of our costs that we're spending for surgery today are on the inpatient side, are on those complicated, extensive surgeries requiring facilities, equipment, and complicated enterprises in order to achieve safe and high-quality surgery. So you're looking at staying away from the complicated surgeries which are inpatient, staying away from the complicated surgeries which are expensive, and focusing on an outpatient platform. This became our mantra. How do we take a piece of that 60, and in fact as much as 70% of the surgical work that we do, and focus on an ambulatory platform? If we get ambulatory surgery initiated in countries where there is no opportunity for surgery in many of the regions, we can begin to expand out over time as experience and knowledge level permits, and also expense level permits, to get to the more complicated stuff. But we don't have to wait and start our process with the complicated things that often derail and stop these projects from the beginning. So now I'll tell you a little bit about our tale, which is a more modern one, which expands over the past 3 to 4 years, to look at maybe we can focus on an ambulatory platform and use that to treat common things: appendectomy, hernia repairs, obstetrical fistula, a huge problem throughout sub-Saharan Africa, prostatic disease, cancers of the breast and other areas, and wounds and orthopedic issues, which are enormous problems in these areas. I can't emphasize enough how often people live with very debilitating surgical problems that we can fix with an ambulatory intervention. This will require us to find regions that are in need, and obviously you can look at that heat map that I showed you before and realize that it isn't going to be difficult to do that. We need an infrastructure that will allow this to happen. And finally, we need to get a training program for local physicians, and this will become a conversation we'll have later, but what it requires to be a competent, capable surgeon to do this defined parcel of surgery versus being able to take care of the global surgical enterprise is something we need to re-entertain and come up with a different paradigm. You know, today when we train a surgeon, they learn to do dozens, if not up to even 100 different operations, but most of you surgeons in the room here could probably say that arguably you do anywhere between, if that many, 5, if that much, 10 different operations at the most in your professional area, since things are so compartmentalized. So I'm not sure that that extensive training is going to be required to get this kind of experience to serve our needs. We began our voyage into this in Africa for all the reasons that I showed you earlier as it relates to that heat map with distribution of disease. You can see the whole good portions of Africa are responsible. You could take a dart, which is almost what we did, throw it at the continent, and wherever it lands, you're going to find a community in great need of the idea of developing a surgical enterprise and an ambulatory surgery platform. So we began by looking around, and we veered away from West Africa at the time, because as we began this project, Ebola was in its full swing on the western part of the continent, and not that there weren't many countries and regions over there that really needed our idea and our concept. If we don't stay focused, as has been learned in many different projects, the project will never be able to be executed because you'll get diluted out by the huge needs. And the needs in West Africa at the time were really targeted around controlling and managing the Ebola epidemic. We looked at the northern regions of Africa and shied away from these because these are areas that have a lot of instability in their governments. There's a lot of terrorist satellites, and I had this idea that if I send my people there to begin to develop this, they get killed, I'd have to replace them, it's very inconvenient. So I chose to spare away from for the beginnings of our project, the northern parts of Africa. South Africa is probably the richest part of the continent. It has tremendous amount of economic growth and has for many years, and arguably has the most well-developed healthcare systems on the continent, and they were probably the least in need of our interest and our help. So we settled on sub-Saharan portions on East Africa, the Horn of Africa, and there were plenty of countries there that would fulfill the requirements that we discussed earlier about need and requirements for physical structures, as we will describe in a moment. As we mapped out the series of countries in that region, we eventually came to choose Uganda, and any of these would have been suitable partners for this project. I had an interest in it. Any of you who are Winston Churchill fans out there will know that Churchill visited Uganda several times and referred to it as the Pearl of Africa. He really saw the verdant, unique, and beautiful nature of the country, and I've always had an interest in it on a personal basis. But also, it's a country that's relatively stable. It's had a stable government now. They must have a wonderful president who's been elected now for at least 7 consecutive terms, so that must mean he's doing an excellent job. And there's been no major civil war type activities in that country for some time, making it an ideal location to consider. So we began to look at partners in Uganda, which began with looking at NGOs that are in operation over there doing medical programs, hospitals, other organizations, because in order to be able to develop this project and also to be able to choose a region within that country, we need to know who our partners could be, who could facilitate the activities. And we began by making a site mission in that country to understand healthcare a little bit better, up close and personal. The first place we traveled to was the International Hospital in Kampala, the capital city of Uganda, and visited this hospital as our starting point. And it was quite, for a country that struggles, a country that has it's one of the poorest countries in the world, with such a challenging economy. It was amazing to see a hospital like this. They had a whole list of consulting doctors who could be aroused within a week's notice. So if you needed a ENT or a urologist, within a week, one of these individuals would be available, because they often traveled around to other sites. They had what I thought was an outstanding ICU with monitoring equipment and capabilities to really manage critical care patients. They had the only neonatal ICU in the country, which could offer care for preemies. And their operating rooms were quite favorable. They had lighting and equipment, which much of it was imported from the West and was well conceived and developed and capable of supplying significant care. The challenge was that the only way you could get access to this hospital is if you paid. Everything was paid up front. There was a cashier in the front, and this hospital served either visitors or the wealthy, and didn't have a mechanism for the overwhelming majority, 99.9% of the population, who were in need of those services. This didn't represent a great partner for us. We then traveled to the eastern part of the country to a hospital called Korsu, which was billed as a rehabilitation hospital, and their wards were like many hospitals we visited in the region: open spaces, mosquito nets, because of the endemic nature of malaria were ubiquitous in this country and in this hospital. And the wards were relatively straightforward. After operations, the patients would recover outside on the open lawn, and they really were doing a fine job, really managing these orthopedic processes. They built what they called their laboratory, which was a workshop to create prostheses for patients who lost limbs, and they even had a very functional and, in my opinion, very well-developed rehabilitation department to train people how to use prosthetic limbs that they could get outfitted for. The problem is that this was more orthopedic focused, and we were looking for a more broader enterprise. We didn't want to replace what they were doing, but really want to get into the depths of other components of surgery that were not managed in any way, shape, or form in a site like this. So this wasn't necessarily a great partner. We then went north to the Kwokum Hospital in Luwero and met with this group, which was a very religious-based hospital, and it was a fascinating thing for me personally to experience this. They were well-equipped, at least as it relates to a small medicine-based hospital. They had a pediatric ward that I show you here. The majority of the care that they provided was for HIV or AIDS. It's a tremendous amount of the population in Uganda, close to 30–35%, has been infected with this, and they've done a very effective job with U.S. help to control this problem. But the thing was that was quite fascinating to me is all the physicians who practice here were all on the missionary cycle. They all were highly religious, and they practiced medicine in a unique way that I had never experienced before. They coupled their religious interests with their medical knowledge. So their religious drives helped them make judgments and decisions about health care, and it was a very well-balanced, perhaps the happiest doctors I've ever seen in my life who were being paid nothing to do their work. So those of you who feel you're being underpaid by your various division chiefs and chairs, if you can describe to a stronger religious part, being underpaid may not be so bad. But this component really made it difficult for us to outfit or conceptualize how we might partner with them, because evidence-based medicine wasn't necessarily the approach that was used to subscribe to the treatments that they were using. We next visited the Nurture Africa group, which was an NGO that was a fantastic group of people who developed a wonderful orphanage and a school, all to manage and train and educate children and help place many of them into homes. And they just were doing a fantastic job at this. And as is the case in many parts of the world, education and schools are very closely allied with healthcare facilities, because you're involved with families and children. This is a big part of where healthcare begins. So they wanted to get going on building and developing a hospital, so they were trying to attract us to consider their activities because they were so good at what they were doing. But it became evident that they needed too much. The resources required to start from scratch without a primary care medical focus, and this will come ring true in a moment when we talk a little bit about some of the other programs we visited. You need to have that relationship between primary care, internal medicine, and surgery. If you separate those two, neither of them function well. Surgeons need internists, and internists need surgeons, and that relationship, which we take for granted in our communities, doesn't always exist. And as we began to get closer on building our surgical enterprise, we realized that we need that piece. Otherwise, we'd have to build it. And building surgery and building medicine all at the same time become an overwhelming chore. Northeast, we went to the Wasoko Diabetes Hospital. This was billed as a diabetes center, which is why I was particularly interested. How do you manage diabetes in a country that doesn't have full access in most of the distant regions to drugs and management and monitoring systems and so forth? It was a relatively simple facility, understaffed, underfinanced, and with an interesting learning lesson for me. When we visited, they had an operating room associated with it, which had not been used, and it had these beautiful lights in it, these portable lights, and this table I show you here, which you can imagine any of you from the operating room here would say that table could easily be in your OR. But the fascinating thing was that both of these pieces of equipment, both the lights and the table, operated on 110 current, and when electricity was available, which was limited, it was 220. So these devices couldn't even function in this environment. And it is a typical scenario that we saw visiting many hospitals throughout the world, but certainly throughout this region of Africa, is that generous people would come by, see the needs in a hospital setting, and then make a donation or buy something and send it over without really understanding the complexities of what they need. In all reality, those of you who work in the operating room can comfortably say that every one of you has electronic tables that bring the patient up and down. But the truth is, a pump action table is probably more than enough for the amount of changes that are taking place in most procedures that we do, and probably are more appropriately suited to this type of community. We visited a group of regional hospitals, of which Ginger Regional Hospital was an example, and it was everything that you've seen. If any of you have watched that, there's a recent Disney movie called The Princess of Katwa, which describes the experience of a young child who grows up, it's a true story, who grows up in one of the ghettos of Kampala, that lives in his destitute nature but has a gift for chess. And the story, I don't want to spoil it, so you can go see it if you haven't already, but they have scenes where the child is taken to their local hospital, and this was a perfect example. I can validate for you that everything you see in that movie is accurate. There's 2 patients per bed, neither of which are necessarily related, often no mattresses on them. Nurses and doctors are limited in many of the settings because of the economics of how people are compensated, and there's an undercurrent of undertreatment, even for severe illnesses, because of the lack of expertise in most instances and sometimes funding. But this hospital was so complicated, particularly because of the government involvement in regional centers, that we would never have been able to break through the political side. You give money, you try to create something, it gets absorbed into various other projects that the government may want or other government officials, and it becomes a delusional effect that makes it impossible to be successful. We then traveled north, which was inspiring, the colorfulness, the nature of the communities. And as you get to the most northeastern portions, which is the majority of the country, the overwhelming majority of people who live there, 99.9%, are subsistence farmers. They basically have a small tract of land, they farm that land, and they feed their families, which tend to be quite large, 9 or 10 children on average. And what's left over, they create these small kiosks where they sell the residual, arguably for cell phone service, because no matter where you go in this world today, everybody has a smartphone. The area was quite beautiful. This is the region which we traveled in the northeastern parts to. This is the Nile River, for those of you who don't know the geography of the area. Now, wait, this is not the Nile where they dropped Moses. That's up north in Egypt. This is the origin of the Nile River, which runs from the south up to the north. And the area was quite beautiful, verdant, and magnificent. Small fishing villages that sit right on the banks of the river. The structures were very interesting to me. They create very simple architectural structures. Everything has a metal tin roof, wood woven, which is then packed with mud and similar materials in one form of building that provides comfortable shelter. Everywhere you look, I thought these guys were squirrels at first, because I've only lived in New York my whole life. I went to New Jersey for an afternoon, came right back, very scary. But these creatures were all over, but I knew, when I saw these monkeys, I knew this was the right place for us to build this. Because about 15 minutes after I saw this nice young lady with her baby, I saw this monkey. I couldn't believe it. I picked up my camera to photograph it, and look what the monkey's doing with the hand. This was a New York monkey. Now, as I studied the picture afterwards, those of you who are orthopedic surgeons in the room will recognize that there's an extensor tendon fracture resulting in this injury, but it sure was a shock when I saw this rather favorable response to my photography. We looked at this community to try to track down a medicine group. We wanted to connect ourselves with a primary care or our internal medicine group so we could begin to develop that alliance that I spoke to you about first. We visited this hospital in Bawinda district. Again, very simple hospital, no physicians on staff. If someone got sick, they would be brought into the hospital, and then there was a rotating physician who would come on an itinerant basis to the region, rather underserved and also problematic. I stayed in this community for 2 days, saw patients, hundreds of patients over a short period of time. Tremendous need there. Again, choosing this as a site, we would have been enveloped in the primary care and the primary medicine side of things and not able to explore what our primary goal was to build a surgical service. We then traveled up to the Kibera area, and this is, again, staying along the Nile River, because this area was a tremendous area of need. Population density was substantive, and there were very limited healthcare processes. We came upon the Allenstone Health Clinic, which was a fascinating learning experience for me. This woman here, Jessie Stone, developed this in honor of her father, who passed away prematurely young, and she was a medical student at New York Medical College in Westchester in Valhalla. And what happened with Jessie is that she had two passions. She had a passion for medicine, and she had a passion for kayaking, and she was a highly competitive professional women's kayaker. And I'm not a kayaker, but as I'm told, it is a great challenge and excitement to kayak the Nile River. The Nile has got some of the most challenging white water for kayakers. That's Jessie there. And this is, I guess, akin with double black in the trees kind of a thing if you're a sportsman. But she traveled upon graduation down to the Nile to do her stint on the Nile Rapids with a friend of hers who sadly contracted cerebral malaria while she was there. And it became obvious to her that the problem of malaria in this local community was dramatic. The population, number of children, every family had at least one, if not two children who had died in youth from malaria. And there was a tremendous misunderstanding about how the disease was propagated. The idea that this was a mosquito-borne disease was completely unknown in this community. And she chose to make this her professional direction. She was going to build a medical health clinic in this area, teach people about infectious disease, most importantly about malaria, and a bunch of other things, and she created a small health clinic that became the dominant health clinic for this community. And patients come in droves. She sees over 8,000 visits on an annualized basis. That number has actually gone up since. And the facility is an inspiration. You know, the roof captures all the water into these side gutters. The gutters are tracked into cisterns or tank receptacles. A small solar panel system set up here that can pump that water up to the top, and she's got running water. Remember, these communities have no electricity, no water, no sewage. All these things have to be considered in the design of what we're eventually going to do and what I'm going to show you in a moment as it relates to surgery. So she became an ideal partner for us to work with for a couple important reasons. One, the thing I mentioned earlier about that relationship between primary care and internal medicine and surgery. But the most important one is she saw many patients where she could do medical treatments, treat heart failure. They were treating a large number of infectious diseases. Vaccinations were a big part of their practice. But this child who came in while I was there would have no opportunity for treatment. And this is something for those of you who are surgeons, ENT and plastics that might be in the audience, would recognize I could fix that. That would not take much, and I could do it on an ambulatory basis. Or this child who sustained a burn exposing his clavicle, which has been exposed like that for now almost 4 years. So he has a chronic osteomyelitis in the clavicle with this open, festering wound, which is painful, but he deals with it. Now, is this going to kill him? Hopefully and probably not, but it is a disability, and it does become something that he has to live with, which we could fix. We could fix things like this. And this young man fell out of a jackfruit tree, trying to pull one of those big jackfruits out, sustained an open fracture through the skin, and just live with it. It closed down, it formed a fistula, the bone sticks out. This chronic osteomyelitis is something we can fix. We can fix things like this, and fix them very fastly and very effectively. But in an environment like this, these things go untreated. If either of these patients with surgical diseases would try to get treated, but they'd have to travel some distance to Kampala, which is centralized over here, as you can see in the western part of the country, or one of those other health systems that can't effectively manage them. So this became our idea, that we would take this Kirabira village, make it our home base, and begin a concept for an ambulatory surgery center, dovetailing it with this medical facility. We provide the high quality care, which is part of the goal of this, not to just build a MASH unit, but to build an operating room setup that any of you in the audience here, should you be visiting that monkey that I showed you before, would be able to get surgical care that you would be comfortable with in an environment like this. It requires a number of important precepts. One, obviously, we need the team. We're going to need nurses, technicians, and surgeons, equipment of all sorts that require, but the simple things that we take for granted when we build our annex on your hospital here or elsewhere is we need a stable source of power. We need water. We need to get rid of water refuse and disposal of garbage. And one of the things that's important for us to do this and to learn from it is to build a communication system so we can either have telemedicine or telesurgical opportunities. Those of you who do robotic surgery can already think about the possibilities. If we could get a stable form of internet access here, what we could do, partnering with groups like you in this audience here and other hospitals in our health system, is quite exciting. And we need a facility that is appropriate to the community. As we started to look at how do we build this, what should it look like, and how do we fit into the community, I started off with this picture. Does anybody recognize what we're looking at here? I'll prompt you. This is the Fifth Avenue skyline with all those famous pre-war buildings, which are exceedingly popular and expensive. And if you look to your far side here, can't get this large building. Anybody know what this is? This beautiful building that beautifully integrates with all these pre-war things here, that's the Mount Sinai Medical Center. And it holds the distinction, the Annenberg building holds the distinction that for 16 consecutive years it's been rated by the Architectural Society of America as the ugliest architectural building in the country. We take great pride in that, and now that we're going to be a team, we all should take great pride in that. important distinction. So we wanted to think about how we put something special in this community, but perhaps something that has a little bit of better tone and is accepted better into the community, as this building has never over the course of its tenure. We began by working with the local community leaders. These individuals are an evolution of tribal leaders, because there are multiple different communities throughout this region, and they're all led by local community leaders at multiple levels. There's LC1, LC2, LC3. These individuals essentially form the governmental structure in these peripheral communities. We started off with working with them, negotiated a price, and purchased a piece of land. This is by deed to the property that we purchased, with multiple witnesses. And we were the proud owners of a large 1.5 to 2 acre section of land for probably an overpaid amount of $2,600. And with this, we began our structure. What do we do? An ambulatory facility can have lots of different forms, and we chose one that would have 2 operating rooms, its own sterilization facility that you see here, its own recovery room, bays for managing the patients and storing equipment and educating people, and also a physician practice, surgical practice wing here, where we have small but defined diagnostic capabilities with X-ray and ultrasound. And off we went to kind of come up with a design consideration. As we looked around, Uganda, which many of you may not know, is the largest grower and supplier of bananas in all of Africa. It's just bananas are one of their main products. So everywhere you look, you see banana trees. Banana trees are everywhere. So on a conceptual basis, our architects came up with the idea that the banana trees, which are ubiquitous to the community, gather sunlight and provide shade for people in the community, because the leaves are broad-based and everything else. And they also harvest energy from the sun, converted into bananas. So we conceptualized the idea of creating a grid of solar panels that will give shade, work as shade producers for people below, harvest the sun, convert it to energy, and it is the energy from these solar panel systems that will have to drive the energy for our surgical center. And this is an artist rendition of the final project, which is underway, and I'll show you some of the next part is just for fun to look at how construction is done in a place that is far and wide from what we do here. We began in earnest in November 28th. This is our groundbreaking, to make it a little bit formal. We got hard hats and everything else in the community, and off we went. The first thing that's done is to grade that piece of land, and what you'll see is everything is done by hand, and we've spent a tremendous amount of time gathering the community interest and community involvement. We've employed large numbers of people from the community so that they're participating in the building of this, they're participating in the conceptual development of this. The likelihood that we'll gain acceptance of this is higher. You know, there's a generalized distrust of people building things in countries like this, because the ideas of altruism aren't always understood. Why would some weirdo from New York want to come down and build something for me down here? There must be some catch. Maybe there's oil in the ground. There's always a belief that not a negative distrust, just a confused distrust to the altruistic concept. So this was an important part to actually slow down our progress in terms of employing the community. We have no major equipment in this area, no big backhoes and things. Everything was done arguably by hand, but you'll see can be done just as effectively as we're doing down in Manhattan, where every other square block there's another new building going up. I will say that it was a shock to me to see that the majority of the workforce, even the physical workforce, was a pleasant surprise to see are women. Women represent a meaningful percentage of the individuals who are involved here and are employed by our organization in the process of this build. So the first part is grading the land to get it level and appropriate, and then the foundation structure is dug all by hand, and this is tough work, but very much welcome. One, because we're building something for the community which they're interested in and excited about, but also creates jobs and a purpose. This is an aerial view, and I learned one of the best purchases I made was to buy a drone, which took some adjustment to the community. Seeing this thing flying over was a little bit distracting to people because they had never seen one before. But once they got used to it, we now run the drone 2 to 3 times a week over the site, and those pictures are dropped into Dropbox, and we can follow movie, video, exactly what's happening on almost a real-time basis as structure goes on. But this is an aerial view of the site with the foundation sites are being dug. And then this has to have reinforced steel in order to hold up a structure of this type. So we have fancy equipment to create reinforced steel and concrete pillars. Here everything is bent by hand, created as such, and then dropped into those individual dug holes with a cement mixer, hand turned and hand crushed aggregate put together to create the pillars that will eventually support the physical structure. This is a piece, I'll digress just for a moment because to me it's fascinating. It's a fallback to almost Egyptian times, but in this country bricks are quite common in Uganda and in many parts of sub-Saharan Africa for building structures. And the beauty of this is you dig down a short distance, 3 to 4 feet below the very rich topsoil, and down there you find this material which is clay. And you take the clay, you put it inside of these little forms, and then you lay them out to dry in the sun for a short period. And then they're stacked up into columns, almost look like chimneys. Wood is thrown inside, they start a fire, and they burn quite avidly and fire the bricks. And once the bricks are fired, they just take them down off the piles, and off they go to build. And here's our team after firing their own bricks, building the foundation. It's much cheaper to build a foundation out of brick than it is to pour it out of cement or use the CMU, those cinder blocks that we see common in this country. This is all available on site. It's cheaper. There's no transportation costs, obviously, and you can build a very functional foundation. At the same time, we have 3 trained masons, and the rest of the force who are building this foundation, a little over 20 people, are getting training on how to be mason, learning a skill. And that's another important part of our project, is getting job training on site, particularly for construction jobs for people in the community. Here they're fixing up materials to create the slab for the foundation, put on top of the foundation, which will form the flooring of the facility. And next, the walls go up. Same firing of the bricks. Bricks are stacked, and the walls of the building are constructed. Here you see a more recent picture where you see the layout of that entire structure that I showed you before, along with the roofing, which is also a important thing. They create this ramp mechanism, wheelbarrow up the cement, pour it onto the roof, and off you go. So this just gives you the layout of what we designed. You can see it almost looks like Machu Picchu or one of those old archaeological relics where the stone walls are there and the ceiling roofs are not quite intact. The building has been a tremendous learning experience, but also a very powerful one to work with the community. And we have a workforce of over 38 people. Almost all of them come from the village. Everybody walks to work, which those of you who commute long distances, particularly on that beloved Long Island Expressway, can imagine how nice it is to walk to work. With the exception of a small number, most of them are unskilled workers who are learning to do these trades. But more importantly, they're taking a possessive or a personal interest in the development of this program in their community that they'll be able to take advantage of. Almost all the equipment and materials come from surrounding areas or are made on site, and the progress proceeds a little bit slower than it might if we had the ability to bring large mechanical equipment into site, but not necessarily problematic as it relates to the quality of the outcome. We have lots to do going forward. We have the concepts of how we train our doctors, nurses, and field staff and how they're funded. A big part of the challenge to these programs is salary. Creating a financial line, which is a little bit part of the bottom line there, that so-called paired business, which we don't have time to discuss today, but to be able to create a business that can generate revenue, that can supply the resources necessary to pay your physicians, pay your nurses, to pay your staff, is going to be an important part of the success. We're building partnerships with other medical facilities in the area. Obviously, we can't take care of everything, so if someone does present with a pancreas carcinoma, we're not going to treat that. We're not going to have the ability to treat that in this site. And having a partner where we can refer patients to and financing those transportations, if possible, will be important. And of course, We're trying to develop appropriate policies, procedures, but not drown ourselves like we've done in this country. And all of you in the room who spend any time in the operating room know exactly what I'm talking about. Focus on IT enhancements are huge, making decisions between whether or not we finance putting underground fiber with the internet capabilities to the facility, which is to the next possible site is a little over 40 miles, which sounds like a long distance, but the cost of labor is such that we could actually drop a fiber in the ground if it's logistically possible. Other possibilities of using multiple carriers with an integrated system, the so-called mushroom device for cellular services, are going to be important. This will allow us to dynamically access the site and help. So if the doctors, nurses, and teams see things that they're not comfortable with, they can have on-call us, meaning everyone in this room and in our healthcare system, to provide knowledge and information and diagnostic work, which is going to be important going forward. This integration between our healthcare system and their healthcare system and allowing our knowledge to help out there is going to be important, and the IT part of this is going to be essential. You can already imagine how telemedicine structures, if they're built well and effectively, can really allow us to offer a lot of health care from New York in parts unknown around the world. We have our own power system, and in the integration of this into the system, maybe distributing some of the excess power that we're creating to the community might be worthwhile for schools and so forth. And the rest of this, water processing and sewage, are all part of the logistics of creating something like this, which turns out to be not as difficult to build a high-quality, high-capable surgical center in essentially the middle of an underserved part of the world. So the future is not just about us as a healthcare system, systems, meaning the South Nassau communities centers and Mount Sinai centers pulling together, but we should begin to look broader and recognize our responsibilities as physicians and as surgeons to the world as it relates to surgical therapy. It's not enough for us to take care of our own communities here and be isolated as some government entities might suggest we should be right now, but we need to take responsibility and take an interest and care for what happens in the future to all of these health programs. I think that's telling me that it's probably time to complete. Thank you very much. If there are any questions, I'd be glad to entertain them.